So I think that a little bit of data that we can use to indicate value for ixazomib in the maintenance setting. So I don't know how you guys view that.
Well, I mean, we're not using a lot of ixazomib maintenance in the U.S., mostly because lenalidomide is such a standard. But let's also remember that, lenalidomide can't always be given. Even in the ECOG study you mentioned up front, remember 51% of those patients came off. In the meta-analysis of the lenalidomide maintenance studies, around 30% of patients had to come off. So we already have almost a third of our patients who can't stay on lenalidomide. Now we could talk about how long they're supposed to be on, but that's a whole other discussion. So I think there is a role for ixazomib. I think even in the discussion in the working group over the last 2 days, I think there was a feeling that ixazomib's role is almost definitely in addition to something else in the maintenance setting.
Exactly.
And so if I have patients that have high-risk disease, or that I want to add something to their lenalidomide, I'll reach for ixazomib, because as you said a few minutes ago, Brian, you're more likely to be able to give ixazomib longer term than bortezomib because of the neuropathy and other concerns. So I don't think it's the lead role, but it's a supporting role, if I can put it that way. And I think that is important for our patients, because we want people to stay in remission for as long as possible. That time to first relapse is so important, and if we can push that out further, that could benefit them.
Yeah, and I think that ability to administer the drug is important, and I think that for that reason there's some European trials where, not just in maintenance, but even in the frontline setting for frail patients, it's part of the protocol.
That's it, in fact. In Europe, we cannot use ixazomib maintenance because it is not yet approved.
Right.
Well, we will see as soon as the drug will be approved if the physicians are using yes or no ixazomib. Currently, as you mentioned, len is standard of care as part of maintenance, and I agree with you, in fact. It could be very interesting to have len combined with ixazomib. We know that the combination of a PI and an IMID, there is a synergistic activity, and we can anticipate that we will delay progression. And there is a very interesting study ongoing in Spain. After stem cell transplantation, patients are randomized to receive len maintenance or len plus ixa. And this is the good study. That's not ixa versus placebo. That's len versus len plus ixa.
Yeah, very good. Okay.
And I think maybe the goal someday would be to find a way to stop. Which are the right patients that we can
Some stopping rules, maybe based on MRD assessment.
Maybe. Although it's difficult. Yeah. We know that when you stop, you're not sure how long will the remission last. It's a difficult decision.
That's a difficult decision. We have to keep in mind the example of CML, for example. It took more than 10 years for us to understand that we could stop Glivec in patients with CML only after 5 years of molecular CR.
Right.
And then half of the patients never relapse. They were cured, and half of the patients may relapse.
Yes.
But we need at least to have this 5 years period of time with a molecular CR. Why not in myeloma, in fact?
Actually, yes, you're right. So I think it's going to take some time, and with the best precise MRD testing that we can come up with, probably.
Yeah.